Hello and welcome back to our tour of bacterial diseases. So we're going to cover the gram-negatives today, and this is going to be sprinkled throughout your textbook. So I've given you page numbers, but here are your basic learning objectives. Hope you're doing okay, and I'm hoping for a good technology day. So the gram-negatives, we're going to talk about the gram-negative cocci, then we're going to talk about the enterics, so those gram-negative bacteria that live in the gastrointestinal tract of humans and animals. Pseudomonas is going to get its own little special sideline, and plus, so like the junk drawer of gram-negative diseases. And so our goals are to be familiar with the pathogenesis, epidemiology, and diseases of these selective gram-negative bacteria. We're going to cover most of them. There's a few that we're going to miss. There's some that are transmitted through bites and wounds, but you can pick that up when you go through your clinicals. As always, I've given you tables. This is, study those. I've made a Quizlet for you. And I really got crazy with those icons, and so hopefully those will be kind of red flags to you, those of you that are visual. Those are the important things. Remember, we are playing taboo, and I'm trying to get you to pick out the particular disease that I'm talking about. So I'm going to try to help you do that as we go through these. So just a reminder, when we're talking about pathogenesis, we're going to be talking about the virulence factors of particular organisms. When we talk about epidemiology, that's when we're talking about what group does it affect, how often does it affect them, what is making it spread, is there a particular time of year. So epidemiology has to do with the factors that affect prevalence, what's the percentage of that disease in a population. Other things too, as we kind of went through the gram-positives and we looked at the spirochetes and the acid-fast bacteria, and we started off this unit talking about microbial genetics and just how there are the core genomic element of a particular species of bacteria, but that there are different strains. And because they have this mobile gene pool, whether it's on plasmids and they transfer that by transformation or phage DNA, they do that by transduction, or they can also just transfer DNA directly through contact by a sex pillet, and that's going to be conjugation. And then of course they have transposons that can move in and out. And then we didn't really talk about genomic islands, but those are other hotspots and beds of genetic recombination. So in all of these, what's going to determine the difference in how a disease progresses from one patient to the next is going to be what strain. And another way to identify the strain, we use serology, so antibodies to tell one strain from the other, because hey, don't all bacteria look alike, right? So that's what's going to determine how a disease manifests itself in your particular patient. So some of these have several different diseases that they can cause. Also, what's going to determine the extent of the disease, and if they get the disease, is going to be that host status. So are they immunocompromised? Are they very young? Are they old? Does this particular disease affect one group more than the other? Are they alcoholics? The other thing too is it depends where these bacteria are located in the body. There's some places that it's perfectly fine to have that bacteria, and then if they get into the wrong organ, that's when they cause disease. So I just kind of wanted to give you that overall big picture. And just reminding you, as we look at that pathogenesis, there's 3 things that microbes have to do to cause disease. This sounds like a theme. This might be like a great question on your final exam, I think. Not that it's cumulative, but this is a theme for sure. So microbes have to stick to you. They have to stay. They have to colonize, meaning they have to reproduce. They need numbers to take us down. So they have to avoid the destruction by the immune system. And then the other thing they have to do to become a parasite is to damage their host. So they have to somehow inflict damage on us, either directly by toxins or through collateral damage through our immune response. Since we're talking about gram-negatives, just want to give you another quick review on the structure of a gram-negative cell wall. So both gram-positive, gram-negatives, they're going to have that cell membrane. There's a periplasmic space. There's a thin layer of peptidoglycan. That's why they can't hold on to that crystal violet in a gram stain, and they stain pink, which is why I made it themed pink. Hope you caught that detail. And then there's a second periplasmic space, and then there's that outer leaflet of that outer membrane that is lipopolysaccharide. So lipid A, and then a whole bunch of sugars, and then this O antigen can be variable. And so this sometimes varies amongst the strains. They're just a little bit different. But we call this outer leaflet, LPS is endotoxin, is intrinsic to those microbes. They're not secreting it. When we discussed the immune system, we said endotoxin in small amounts is somewhat beneficial if it's a small amount and it's also localized, meaning it's not systemic or in the bloodstream. Because, remember, we talked about toll-like receptors and pattern recognition receptors, we don't have lipopolysaccharides, so that is going to stimulate the immune system. So we get cytokines, the immune system gets activated, so we get our immune response. So localized inflammation is good, sets the stage for repair. We're going to get antibody synthesis, all good. Vasodilation is going to call those white blood cells to the area. And then fever also, low-grade fever is helpful in activating our immune system. So small amounts are good. Large amounts, very, very bad. When we get that lipid A, lipopolysaccharide, that endotoxin in large amounts, particularly when it goes systemic, we get that cytokine storm that's going to do a whole lot of damage. And that over-exaggerated immune response is sepsis. Your patient's going to look like death. They're going to feel like death. And then if it goes further, then we get, in this case, we're going to call it endotoxic shock or septic shock. And we become shocked when there's that dangerous drop in blood pressure because all those capillaries get leaky at once. So low blood volume, low blood pressure, and disseminated intravascular clotting is going to damage organs and cause them to shut down. So what happens with the gram-negatives when they die or lyse, and some of them just like to blub off little pieces of LPS, that's when there's too much LPS, that's bad, can lead to sepsis, we're going to call endotoxic shock, and then of course, if a patient goes to septic shock, that is the #1 cause of death in the ICU. And we learned that already, so just kind of reminding you that cytokine storm, too much is not good. And the only thing we've added to this is just another term if you hadn't ever hear endotoxemia, that has to be from a gram-negative. All right, so our only genus of pathogenic gram-negative cocci are the Neisseria. They are Diplococcus. They kind of look like two coffee beans kissing because when they divide in that one plane. Strangely enough, both of these diseases, which we'll talk about in a second, they do not make any exotoxins. So their damage is strictly from their endotoxin and then our immune response. Like I said, this is a Neisseria, I can't remember which one, but it is just pinching off little pieces of endotoxin, which drives our immune system crazy. So the two diseases, Neisseria meningitis and Niceria Gonorrhea, these are where you can find it in your textbook. This is a table for you. Our first Neisseria is going to be Niceria meningitis. You can see, you can probably guess that it causes meningitis. Another name for it is Meningococcal because it is that Diplococcus. There's 12 different strains. We'll talk about that in a minute. So we already talked about Streptococcus Pneumoniae, and that is the #1 cause of bacterial meningitis in adults. This one, to make it different for you, is the most serious of acute forms. Most serious meaning that 15% of people that even get treatment are going to die. Because it is so serious and leads to death, we have a vaccine for it. The thing is, the vaccination schedule, usually people are not vaccinated to age 11. You get another one at 16, and then you get 2 before college. So who is going to be affected by this are the young. So your 6 to 36-month-olds, so your babies, and then it's highest in the rates of 10 to 20-year-olds. This too is also sometimes called epidemic meningitis because it tends to crop up in outbreaks. And usually it's going to be in colleges or military dormitories, so where young people are living in close contact, and usually it's going to be in the winter. The reason that this is never going to go away is because they're asymptomatic carriers. It lives in the nasopharynx. So where is it? There we go. And so it's going to be in the nasopharynx. So it's part of normal microbiota. And strangely enough, they did a study that they realized in younger persons, that carrier rate is even higher. So up to 40% of people in dormitories, like you guys, college-age students, or in the military, are colonized with Neisseria meningitidis. One thing that can help babies as prevention is when mothers breastfeed. So progression of disease. So someone, it's going to enter through respiratory droplets. Someone's going to have a cold-like sort of feeling, a little malaise. Someone's going to have headaches, a really sudden onset of a very high fever, about 104, stiff neck, vomiting. As far as virulence factors, Neisseria meningitidis, they have pili for attachment. They have a capsule that helps them evade the immune system. They can evade mucous membranes, so they can go into the bloodstream, and that's how they're going to travel. A calling card, another thing that makes it different from other types of meningitis, is petechiae. Yep, that is what this rash is called, so petechiae. And that is due to that cytokine storm underneath the skin causing vascular damage. Then it affects the outer coverings of the brain and the spinal cord, so you get meningitis. And it's that inflammatory response that's doing the damage. It blocks the flow of cerebrospinal fluid. Can even lead to paralysis, so because the brain isn't going to be able to function, and then you get endotoxin release in the bloodstream, and that can lead to shock. So it is the most deadly of the meningitises. So looking at this capsule, remember capsules help resist or prevent opsonization and phagocytosis. They also have IgA protease because remember they're going to enter through mucous membranes, and normally IgA antibodies are in our secretions that help protect us. There are 12 different serogroups, so based on capsule and other surface proteins, there's 12 different strains that can be identified by serology, so using antibodies, to that polysaccharide capsule or those surface antigens. So therefore, we have anti-capsular vaccines. And the capsular antigens, they're given letters, so B, C, Y are the most common, and usually those epidemic outbreaks is going to be that capsule B. And this is why you guys probably had to at least give a statement about your vaccination against bacterial meningitis. And once again, there's meningococcal disease. And the problem with this is even if you recover, a lot of times there is permanent damage. And so once again, when something's super serious, we are going to make a vaccine to protect our population. And so it is going to be the unvaccinated. Also, it is transmitted through close contact. And I don't know, young people are just a little closer than the older people. And that's for you. Our second one is Niceria Gonorrhea. And remember how to spell it. Gonorrhea. Yep, that's how I got through microbiology. We used to have to write things out. It wasn't multiple choice. This one too is called Gonococcus because, it's a diplococcus. It is number 2. It is the second most common sexually transmitted infection. The thing is usually asymptomatic, which is why they changed it from STDs, disease, to STIs, infections. So asymptomatic, 60% in women, and we'll talk about complications to this, so sequelae, is going to be pelvic inflammatory disease. It is more commonly going to be symptomatic in men, so it causes gonococcal urethritis, and so you get purulent discharge, and usually that's going to, cause a man to go to the doctor and get tested, and then he's going to get treated. So it's asymptomatic in about 20%. And let's go down here. Remember, Neisseria gonorrhea, they have those pili for attachment. They're going to use antigenic variation. They also are going to use phase variation in their surface proteins. So yes, you can get gonorrhea over and over again. So there's no vaccine available for it, and having gonorrhea once will not give you immunity. So those complications or the sequelae. So gonorrhea is number 2. The next one we're going to talk about is chlamydia, and it is number 1. Because it's asymptomatic, but yet it is still growing and the immune system is still responding, what happens particularly in women in the fallopian tubes, if there is chronic inflammation, what you get is scar tissue. And the uterine tubes, aka fallopian tubes, especially right here is the isthmus, they're very narrow, so any sort of scarring can cause closure. Usually, when a woman becomes pregnant, what happens when she ovulates, she releases the oocyte, it gets swept into the uterine tubes, the sperm go through the cervix, the uterus, and then fertilization occurs in the uterine tubes. Then that conceptus is going to drift through the uterine tubes and then implant in the uterus. So what happens if there's scarring in these uterine tubes is the conceptus, at that time, it cannot fit. And so you can get what's called an ectopic pregnancy. So ectopic pregnancy is a pregnancy anywhere that implants outside of the uterus. So this is where the baby's supposed to grow. That pelvic inflammatory disease, because the female reproductive tract is not closed, you can also get bacteria out here in the peritoneum. So it can cause other issues as well. Honestly, if a woman's lucky, she's going to have symptoms of this. She'll have a fever and abdominal pain, and then she's going to go get treated. But what can happen is this could be subclinical or asymptomatic, so a woman doesn't get treated, and that's when you get infertility. It is estimated that 6 million women in the United States have impaired fertility, mainly due to the fact that STIs are often asymptomatic. So number 1 is going to be chlamydia, number 2 is gonorrhea. If you have an incidence of pelvic inflammatory disease, 15 to 24% of the people that have them are rendered infertile. It increases the risk 7 times more of that ectopic pregnancy just with one pelvic inflammatory disease. So left untreated, like I said, we get that inability to get pregnant or pregnancy complications. Because it's more symptomatic in men, they often get treated. It can cause problems in men, but just not as often, so it can affect the prostate gland. You get prostate abscesses. And then there can be scarring of the men's tubules in the testes that are used for sperm transport, but more often than not, it causes problems in the female. Yeah, so how is Texas as far as rate in the populace? We are number 22, so we are actually, our numbers for gonorrhea are going down. So we're number 22. We have 155 cases per 100,000 populace. This is reported, by the way. So the reported cases, not the asymptomatic cases. You want to know who's number 1? Take a look. What do you think? Oh, Washington, D.C., our capital, ladies and gentlemen, where our politicians are, and there are a whole lot of prostitutes that work in D.C., and yes, they are, oh my goodness, more than double the rate of Texas. It's a fun fact. Yeah, so one of the reasons, so as far as progress of disease, once again, they have those pili for attachment, and they have that antigenic variation. They can attach to any non-ciliated mucous membrane, so yes, you can get gonorrhea in the throat. Phase variation of surface antigens, so you don't get immunity. They have IgA protease. Immune system is going to respond to that endotoxin. That's what's doing the damage. Most of the time, gonorrhea is going to stay put as far as going systemic in the bloodstream, but a strange complication, if there's going to be one, a lot of times it's going to be arthritis in both sexes. It can also go to the heart valves, cause endocarditis, and it can go and cause meningitis, but it really goes systemic. Usually, though, you're going to see that arthritis. Thing is, STDs, so gonorrhea and chlamydia, if a pregnant mother has the disease, when the baby is born and exits out the vagina, then you get that vertical transmission. What it's going to cause is neonatal conjunctivitis. This can also lead to blindness. So in the United States, there's prophylaxis, so prevention of neonatal conjunctivitis. When a baby is born, they use antibiotic ointment on the eyes. We used to use silver nitrate, but that caused other issues. So now they just use every baby that's born, get some antibiotic cream in their eyes. Other parts of the world, this is not done, and so this is one of the causes of preventable blindness in the world. Number 1's gonna be chlamydia.
Gonorrhea is a major public health concern in the United States. More than 800,000 new infections occur each year, but because many people don't have symptoms, fewer than half are detected and reported to CDC. Untreated gonorrhea can cause serious health problems. For women, it can increase their risk for a life-threatening ectopic pregnancy. And for men and women, the infection can cause conditions that can lead to infertility. It can also increase a person's risk of getting or giving HIV. Medication to treat gonorrhea has been around for decades, but the bacteria has grown resistant to nearly every drug ever used to treat it. In the 1980s, resistance to penicillin and tetracycline grows, and they are no longer recommended to treat gonorrhea. Fluoroquinolones are the leading drugs to treat gonorrhea in the 1990s, but the bacteria was adapting to the drugs. By the 2000s, resistance to fluoroquinolones steadily takes hold. CDC modifies treatment recommendations throughout much of the decade to keep pace. In 2000, the drug is no longer recommended to treat people infected in Asia or the Pacific Islands. By 2002, this recommendation extends to California. By 2004, CDC no longer recommends it for men who have sex with men in the United States. By 2007, resistance is so widespread that CDC no longer recommends fluoroquinolones to anyone in the U.S. to treat gonorrhea. Only one class of antibiotics, known as cephalosporins, remains to treat the infection. There are two main cephalosporins to treat gonorrhea: the oral drug cefixime and the injection ceftriaxone. In 2010, CDC takes additional measures to combat resistance, recommending dual treatment with either cefixime or an increased dose of ceftriaxone and azithromycin or doxycycline. But just 2 years later, in 2012, CDC updates treatment recommendations again in response to data suggesting the oral cephalosporin cefixime is becoming less effective and gonorrhea has become harder and harder to treat. Today, we are down to one last recommended treatment option: dual treatment with an injection of ceftriaxone and an oral dose of azithromycin. Little now stands between us and untreatable gonorrhea. There are already troubling signs with the last recommended treatment. Abroad, infections resistant to ceftriaxone have been detected in several countries. And within the U.S., while not common, resistance to azithromycin has been found. The U.S. hasn't seen treatment failure when using these two drugs together, but drug resistance is rising, and the pipeline for new drugs is shrinking. Our last treatment option won't last forever. We must keep drug-resistant gonorrhea as a leading priority. Learn more at cdc.gov/std/gonorrhea/ARG.
I don't know if you caught that, but drugs used to be good for about a decade, and now we've been cycling through different antibiotics and dual therapies about every 2 years. So that's for you. But a big thing, prevention, is going to be abstinence, monogamous relationships, condoms. Basically, people need to talk before they have sex, so talk, get tested, and then get treatment. So our last one in this video is going to be Chlamydia Trachomatis. And this is the numero uno, not just number one STI, but it's the number one reportable bacteria infection. 1.59 million just reported cases in 2017. And just to wrap your mind around this, 75% of women and 50% of men are asymptomatic. So you do the math. These are the people that had symptoms and knew that they had something and got tested. These people didn't. So symptoms are usually going to appear about 7 to 14 days, and it is going to be urethritis in males, so painful testes, pain on urination, possibly a fever. In women, usually it's going to be increased vaginal discharge, which most often is going to go unnoticed. Possibly if it gets in the urethra, painful urination. Lots of times there's abnormal bleeding, so spotting in between a woman's cycle, but that doesn't often tip her off that something is wrong. If it goes to a pelvic inflammatory disease, then there's going to be that abdominal pain. Once again, just like in gonorrhea, this is going to infect can be vertically transmitted as the baby is passed through the birth canal and cause that conjunctivitis. It is the #1 cause of preventable blindness in the world. Once again, good old US, we use prophylaxis whenever a baby is born, so we don't have that sort of rampant blindness. But other parts of the world, high rate of chlamydia, and then that vertical transfer, so you get neonatal conjunctivitis, which leads to blindness ultimately. And how are we in chlamydia? We are doing better, Texas. We used to be number 15, and now we're number 18. And oh, look, #1 again. Good old Washington, D.C. Yes, more than double our rate. Like I said, keep in mind, all these numbers are adjusted per population. So chlamydia is our example of, Chlamydia trachomatis, the causative agent, is an obligate intracellular parasite. So remember, obligate means you must do it. They can only reproduce inside of a cell. They are technically gram-negative bacteria, strangely enough. So they're really, really small. They have DNA, they have RNA, they can make proteins, they can make their amino acids. They cannot make their own ATP, which is why they are obligated to live inside of a cell. They have an inner membrane and outer membrane, but they actually don't have any peptidoglycan, so they get kind of lumped in with the gram-negative bacteria. So the infectious form is going to be called an elementary body, and this elementary body can survive outside of a host cell. And so this is what is going to attach to mucosa, so any unciliated mucous membrane, and it induces endocytosis. Then inside of the host cell, then it forms what's called a reticulate body, and that is what is going to basically replicate. And so it does it through binary fission. That's how bacteria reproduce. And then once it goes through binary fission, then it's going to form those elementary bodies that are going to split off, and then that is the infectious form. So it just has a unique life cycle, but is the #1 reported sexually transmitted infection. #1 cause of pelvic inflammatory disease. And so that is there for you. I think we hit everything. Okay, I'm going to wrap this one up. Thank God my computer did not shut down. It's going to be a great day, ladies and gentlemen. You go off and have fun.